Hello everyone, today we will resume our lecture of management of venous ulcer in the second part, treatment of etiology. This is the chart for American Venous Forum guidelines about how to treat the etiology, different causes and etiology of venous ulcer, either refluxon and obstruction. For the refluxon, we have refluxing superficial veins or axial veins related to ulcer. You have to treat them endovascular or by using open technique like strabing ligation. And then we have refluxing perforators related to the ulcer bed, and you have to treat them. If both management has been failed, you have to re-evaluate about missed superficial axial or perforator veins to be retreated. And you have to make in your mind there's also refluxing deep venous system, which has suggestion of treatment by valve reconstruction. In treatment of the obstruction, the proximal suprainguinal lesion is best treated by endovascular, by stenting. Failed intervention need the unilateral bypass. Infrainguinal lesion may have required phlebectomy and the AV fistula. Failed would have also bypass. Superficial system perforators and primary varicose veins. In patient with pigmentation C4, failed venous leg ulcer C5, active venous ulcer C6, with incompetent superficial axial veins and pathological perforators, that means outflow more than 500 millisecond duration, with a diameter of more than 3.5 mm, located beneath or associated with ulcer beds. We suggest ablation of both incompetent axial superficial veins and perforators to treat the ulcer and to prevent recurrence. Treatment of the incompetent perforator veins can be performed simultaneously or can be staged with reassessment and re-evaluation of the perforators after treatment of the axial veins. Treatment of the superficial systems is well known by many of us, like using radiofrequency ablation, endovenous laser ablation, MOCA, ligation, and many other techniques. But we'll emphasize on the management of perforators. If we have the lesion like C4, hyperpigmentation, lipodermal sclerosis, C5 healed ulcer, C6 active ulcer, and it's related to axial and perforators. And you have tried to treat the axial refluxon, and you have tried to use compression therapy, and both of them are failed. You have to assess the perforators. Perforators with diameter more than 3.5 mm at the fascia, refluxing more than 500 millisecond duration, denote pathological perforators that mean that require intervention. And this is the current American Venous Forum guidelines. This is the picture of pathological perforators. And if you have set the distance from this point to this point, you will find it more than 3.5 mm. And this is the refluxon present in the pathological perforators. Management technique of the incompetent perforators. This slide has taken from my friend Dr. Fathi. Open surgery, subfacial endoscopic perforator surgery, and percutaneous ablation of the perforator veins, laser ablation, radiofrequency ablation, and sclerotherapy. Open surgery is first line of treatment of the perforators. Invasive technique which carry high morbidity and need hospitalization or delay ambulation. 5% of the perforator are usually missed. Recurrence rate of the perforator is 32%, half of them being incompetent. So the open surgery is invasive technique and carry high morbidity with the risk of missing perforators. Subfacial endoscopic perforator surgery. This is the picture of subfacial injection of gas and using port to make flipping ligation of the perforators. Less invasive than open surgery, with less surgical complication but still invasive. Better result if compared to conservative management in active ulcer, limited by inability to access all incompetent perforator and to discriminate between competent and incompetent perforator at the time of treatment. Minimally invasive procedures. Minimally invasive procedures is percutaneous ablation of the incompetent perforator either by chemical or thermal energy. Office-based procedure with no need for hospitalization, fewer complications, more comfort, early recovery, and ambulation. Sclerotherapy. The use of sclerotherapy or sclerosing agent to produce endothelial damage and closure of the perforator veins. Multiple agents are used as a sclerosant. Osmotic agent, alcohol agent, and detergent agent. 1 unit of liquid sclerosant is mixed with 5 units of gas to make thick foam that replaces the blood in the target vein and be in direct contact with the endothelium. So the main pathophysiology of this agent is making endothelial damage and closure of the perforator veins. This is the technique. 18 gauge needle is used to access the target perforator under ultrasound guidance, then injection of the foam gently. During injection, pressure is done for 2 minutes at the junction of the perforator with the deep veins to prevent sclerosant to get into the deep system. Caution should be done to avoid adjacent perforator artery. Best done by injection 1 to 2 cm away from entry point into the fascia. Complication of the sclerotherapy. Local complication, allergy reaction, phlebitis, hyperpigmentation, extensive skin necrosis due to injection into the adjacent perforator arteries. General complication, DVC, subsequent pulmonary embolism, anaphylaxis, case report related to systemic embolization including transit loss of vision and stroke have been reported. Radiofrequency ablation of the perforators. 6 French 12 cm rigid catheter is specifically designed for perforators. Found package mounted on stilts that can be used directly or over 0.35 guide wires. And this is the technique of radiofrequency ablation of the perforators. This is the catheter of the radiofrequency and this is the pathological perforators, which will be obliterated later on. Endovenous laser ablation of the perforators. Ultrasound guidance puncture of the perforator by 21 gauge needle, passing of 0.018 guide wire, insertion of the 5 French micropuncture sheath over the wire, passing of 400 nanometer fiber catheter into the vein, injection of lidocaine tumescence surrounding the vein, start ablation using energy produced by laser wave, and all these procedures is under control and guidance of ultrasound. Result of thermal ablation of the perforators. Great result with closure rate ranging from 61% to 95%. Early closure rate is better than it with sclerotherapy. Closure rate of laser and radiofrequency ablation after failure of the sclerosant is 25% and 29% respectively, compared to 50% with second trial of sclerotherapy. Complication of thermal ablation of the perforators. Local complication, ecchymosis, induration, paresthesia, or vessel perforation. Rare general complication, DVC, pulmonary embolism. Conclusion, pathological perforator which is incompetent. The size is 3.5 mm in diameter. Reflux flow is more than 0.5 seconds in patient with chronic venous disease C type 4, 5, and 6. Must be interrupted after elimination of the superficial axial venous reflux and failure of the compression therapy. Invasive surgical techniques like open surgery or subendoscopic are abandoned to open new era of minimal invasive technique like radiofrequency, endovenous laser ablation, or sclerotherapy. So after discussion of the etiology and treatment of the diffraction, we'll discuss now about the occlusion. We have two types. We have post-phlebitic due to old DVT or non-thrombotic due to maternal syndrome. National guidelines indicate that it is reasonable to perform balloon angioplasty and stenting to correct an underlying or residual iliac vein obstruction of inferior vena cava or iliac vein or severe stenosis. And this have been mentioned in ACCP and American Heart Association, Society of Vascular Surgery, American Venous Forum. American Heart Association guidelines indicate that residual obstruction of common femoral vein may be treated by balloon angioplasty alone without stenting. This is a picture of lesion present in the left common iliac vein that have been treated by stenting. Pathophysiology of the obstruction. The ambulatory venous pressure will increase is low in healthy subject, will be increased with superficial insufficiency and then more in the deep insufficiency or refluxon and more in the deep venous obstruction. So deep venous obstruction will markedly increase in ambulatory venous pressure. This is the hemodynamics in case of the complete venous obstruction in the iliac trachea. We will find the pressure in the common femoral vein will be markedly increased. If there is occlusion in the iliac vein, then non-occlusion of it. Peripheral venous hypertension and chronic venous disease. Both obstruction and refluxon lead to venous hypertension in upright position, more severe in obstruction. But in supine position, only obstruction leads to venous hypertension. Ambulatory venous pressure will be increased by defect in many points. This is the normal. We have arterial inflow, we have muscle pump, we have refluxing or non-refluxing veins, and then outflow. So if we have increasing of the superficial refluxing, it will increase the outflow of the vein and increase the ambulatory venous pressure. If we have failure in the muscle pump, it will increase ambulatory venous pressure. If we have increase in the arterial flow like in arteriovenous fistula, it will increase the ambulatory venous pressure also. There is a different type of post-thrombotic refluxon affection of the valves, and after the thrombosis and subsequent inflammation will have different type of refluxon, and refluxon will be shorten the duration of ambulatory venous pressure. Conclusion. Reflux may initiate shear-related valve damage, vasodilatation, microvascular injury leading to edema, tissue damage, and ulceration. Refluxon doesn't defeat colon segmentation per se, but shorten duration of the ambulatory pressure recovery. The effect of refluxon cannot be considered in isolation, as cuff pump function can compensate for it, or make it worsen if cuff pump is compromised. Cuff pump abnormality may be presented without reflux. The importance of the venous obstruction has been recognized recently, and treatment of obstruction is much more important than refluxon in the venous system. And the assessment of the obstruction depends only on morphological methods. Literature. Treatment of the superficial and perforated refluxon and deep venous stenosis improve healing of chronic venous leg ulcer. In patients with deep venous stenosis, significant healing benefit was seen with stenting compared with compression therapy or superficial truncal ablation with or without perforator ablation. That means he preferred to do treatment and correction of the deep venous obstruction in the first. And this slide has been taken from Dr. Galai. And this is the classification of Dr. Human Galai out. We have classifications that try to make how you can treat obstruction of the deep venous system. If you have stenosis or May-Turner syndrome in the left common iliac, could be treated by endovascular. Occlusion of the left common iliac, level of common iliac and extending iliac, endovascular. Occlusion that reach to the common femoral but spare the profound femoris and femoral vein could be treated also by endovascular. But if we have involvement of the femoral or profound femoris, you have to make an option of hybrids. Hybrid mean phlebectomy and endovascular management with standing extension either into patent profound femoris or patent femoral vein. But if we have no inflow, occlusion of the profound femoris, femoral vein, occlusion of the common femoral, external common iliac is contraindicated to be treated. It needs all the conservative management. Appropriate large diameter stent and ensuring good inflow and outflow from the treated segment are very important for treatment. 12-40 mm stent in the external iliac, 40 to 80 mm stent in common iliac is adequate in most cases, and it is guided by IBUS. Most post-thrombotic patients require stenting of the entire segment from C-felt common femoral to common iliac vein vena cava junction. A stent has been safely placed across the inguinal ligaments. And this is different type of the dedicated venous stent. Be careful, too small stent is liable to be falling down. It will be not efficient in treatment. This was the only 10 mm stent which thrombosed later on. Now we are discussing 3 cases of how to manage obstruction and reflux. The first case from Dr. Human Galai, chronic venous obstruction of the right common iliac vein, and we have dilated varicosities and reflux and crossing varicosity to the other side. Left side has mild compression by May-Turner syndrome. Patient is complaining of right side swelling, tension, heaviness, moderate abdominal collaterals, venous claudication, and cosmetic. But left side has distal edema, tiredness, and cosmetic. Treatment the first is the treatment and correction of the obstruction, stent of the right common iliac vein, and then follow up for 6 months. And then treatment of the varicose veins at right side, staged fashion. And then treatment of the varicose veins at left side. That means it's not necessary every case of May-Turner to be treated, being we don't have a definite portal what's meaning of May-Turner syndrome and when to treat it. Second case, 68-year male with peripheral arterial disease underwent below knee bypass at 2018, wound healing disorder with severe lymphorrhea and hyperpigmentation. This is the bypass, and this is pigmentation present below the knee, and he has a healed ulcer, and this point is active ulcer. And this is the investigation. MRT with contrast, we have occluded common femoral vein. So combination angiography, we'll find that we have femoral vein, we have occluded the profound femoris, we have great saphenous vein reflux. This is the bottom 3 inflow: femoral vein, occluded profound femoris, refluxing great saphenous vein, and then occluded common femoral vein, collaterals getting them to the external iliac vein, which is also stenosed. Then management by endovascular, pre-dilatation 14/40 high pressure balloons, and then using dedicated venous stent 60/140, 40/100 millimeter, and finally they give us a fantastic completion angiogram. And this is the post-operative ultrasound evaluating the common femoral vein and evaluating the external iliac vein. This is also ultrasound postoperative, and is the final outcome of healing of the ulcer. Third case, it is from American Venous Forum lectures. 89 years male with history of lower limb edema swelling since football injury to groin at age of 14. Swelling which hadn't bothered him until he began to develop pain and ulcer on his left medial malleus, in his lateral medial malleus past 2 years on the left side. No history of DVC, no venous claudication, wound center for local care. So this patient has a history of trauma. Maybe this trauma caused thrombosis, all DVC, both phlebitic, and now he presented with ulceration C5 or C6. This is the ulcer, it's about 5 centimeters in the length, and we have discussed in the first of our presentation, you have to make documentation and measurement. Procedure after discussion with the patient. I think there is some missing information in this case. This case has, as we have said in the ultrasound, he undergoing ultrasound later on. He find that there is occlusion in the common femoral vein. We have a refluxing superficial venous system, and diameter of the great subvenous vein about 8 millimeter, and we have refluxing perforators related to the ulcer. So the management was ascending venograph, access from the great subvenous vein, only ballooning for common femoral vein and external iliac vein with final 14 by 60 millimeter balloon, and he didn't use stenting. As we have mentioned, in American Heart Association, it's not necessary to make stenting if the lesion only present in the common femoral vein. And the second session to treating the axial refracting veins. He is treating the great subvenous vein with endovenous laser ablation, thermal, and he is treating the perforators, incumbent perforator related to ulcers by using sclerotherapy. And he's continue on the enoxaparin for 6 weeks, then comazine for 3 months. And this is the pictures, diagnostic IVUS for the left common iliac vein and left external iliac vein before treatment. This is the diagnostic venogram after popliteal access, and we have common femoral vein occlusion, which was treated by balloon only angioplasty, and the ulcer has been correctly healed, and this strategy was perfect for him. Finally, infrainguinal deep venous obstruction and pigmentation C4B, healed C5 or active C6 with venous leg ulcers. This is the recommendation of American Venous Forum, and they told us that infrainguinal lesion we have a chance to do and venectomy. We suggest autogenous venous bypass or phlebectomy in addition to standard compression therapy to aid in venous ulcer healing and to prevent recurrence. And this is the incision of the vein, and you can find the replication of fibrosis, which is the main pathophysiology in the post-phlebotic syndrome. This is the technique of phlebectomy and bypass. After exposure of the common femoral vein, incision and venectomy and phlebectomy and removing of the fibrosis, and then using venous patch or bovine pericardium patch and arteriotomy inside the bovine pericardium, and later on using 6 millimeter BCFE as AV vesicle between the common femoral vein and artery. And then you have to follow up for about 3 months, and later on you can occlude this AV fistula using endovascular technique like plug embolization. This technique is as suggestive as a management for the infra-inguinal lesion. And the completion of your proximal treatments by stenting, and stenting could be crossing the inguinal ligament and could be overlapping with the IVC. As we have discussed before, you are using IVC, you cover all trabecular lesions, you have them to assist good inflow and start from healthy point to healthy points. Thank you very much for your attention.